Good afternoon, everybody, and thank you for coming. My name is Larry Burnett. I'm a shareholder here at Reinhart in our Business Organizations Department. In fact, I'm a co-chair of our department, and I am not an expert on the Affordable Care Act. Luckily, we have several people who are. As part of my job as chair of the department, I felt it was important for us to begin to educate our clients on what the Affordable Care Act meant for them. And with my three colleagues here, we've developed a seminar that I didn't develop it, they did, that we are presenting to folks so that they have a better understanding of what's coming. The Affordable Care Act is really transformational for a lot of our clients and our businesses. It will have a profound effect on employers. It will force them to ask some fairly significant strategic questions, such as with potentially increased employee costs, how do I expand? How do I manage these costs? How does this affect a capital investment strategy? Do I get out of the health insurance business? Or, as an alternative, do I get more deeply into it by self-insuring? When will we get certainty? And perhaps the most pervasive question that I've heard companies ask is, what is the best thing for my company and my employees and their families? There's an odd thing, and that is that most companies really care about their employees and what types of benefits they have. So my colleagues here are Greg Storm, Kristen Bergstrom, and Gail Olson, and all three of them are shareholders in our benefits group and are extraordinarily knowledgeable about this. We have an hour allotted for this. I'm sure there are going to be a lot of questions. Somehow or another we can get those answered from the people on the webinar as well, but feel free to ask any questions that you have. Thank you.
All right, well, thanks a lot, Larry, and thanks to everybody for attending today's presentation on this beautiful spring afternoon. I'm sure that there is no place that everyone would rather be than here in a conference room with the blinds drawn and the dark cloud of the Affordable Care Act hanging over each and every one of you. Before we get started with the official presentation, just a couple of overview points to talk about what we're really going to try to accomplish today. I think the first goal and our primary goal is to try to educate everybody on the Employer Shared Responsibility Rule, also known as the Employer PayorPlay Rule, effective for most employers January 1 of 2014, assuming that you work off of a calendar year plan year for your health plan. We're going to try to keep this at a fairly high-level discussion. We're not going to dive into all of the detailed, complex rules that relate to the Employer Shared Responsibility Rule. Each of us have done the 2 to 3 hour long, painful presentations and client meetings where we talk in great detail about the measurement periods and stability periods and defining exactly whether or not a certain individual would be a full-time employee for purposes of this law. And we'd be happy to do that with anybody who's willing to undergo that type of torture. But for today, we're going to try to just keep it at the basic level. And we think that the presentation we've put together is beneficial for people at on all parts of the learning curve for the Affordable Care Act. If this is the first or second time that you're hearing about this rule, the presentation should help solidify what exactly you're required to do as an employer. If it's the fifth or sixth time that you're hearing about the rule and you've sat in on a number of webinars and seminars in the past, then this will help to, reinforce your understanding. And hopefully, and this is where I think we'll try to distinguish our presentation from other ones, this presentation should give you some ideas of how exactly the law applies to your particular circumstances. We'll try to use some anecdotes. We've got some brief case studies that discuss how the law applies and how we've run into it with some of our existing clients and prospects up to this point. And those types of conversations can put you in a position of looking and saying, okay, now I can start to see how exactly this rule might apply to my organization. So I guess the second point or the third point that we'd want to mention is that we really want to get you down the path of making a strategic commitment to studying healthcare reform. We think that this law has great implications not just for 2014 but in the future. The bulk of what we're talking about today is focused on getting you compliant for 2014. But at the same time, as you're thinking about how will you comply for 2014, what changes you may have to make, you'll also start to look forward to, and we'll briefly touch on a couple of things that take effect in later years beyond 2014. So with that said, I guess the first thing is what's the rush? We're actually still getting this question from a number of clients. They look at it and they say this law is effective in 2014. It's only early May. Why do I have to start planning for it right now? Can't we come back and talk about this in September or October after I've taken a vacation and after the summer is done? And the simple answer is no. You really should start trying to plan for compliance with this law now. We had a number of clients that looked last year and said, well, I'm going to postpone planning for 2014 until after the Supreme Court case. And then they said, well, I'm going to postpone planning about the 2014 rules until after the elections in the fall. And we still have a few people that are saying, hey, I've heard that there's a rumor about repeal of the healthcare reform law, or there's a new lawsuit that's challenging it. And in fact, I just saw something in today's New York Times that mentioned that in a recent survey by the Kaiser Family Foundation, 4 out of 10 Americans, they recognize what Obamacare is, or the Obama healthcare reform law, and they had no idea that it was actually a law that applied in this country. Unfortunately for all of you, that type of ignorance will not benefit you. So now is the time to start planning for compliance for 2014. And the biggest reason is that what we found in the discussions with clients up to this point is that a lot of the items that you'll have to take care of to comply with the law may or will, in fact, require changes to your operations. And these are fundamental changes to how you run your business, and it's going to take some time to implement those changes. For example, and this might be a little bit of an extreme case, but I know we've talked with some clients about actually changing the legal structure or the ownership of the organization. Particularly, I think in the small business context, this might be a little bit more attractive to try to avoid some aspects of law. Secondly, hiring and staffing. How are you going to characterize certain employment classes and the roles of those employment classes on a going forward basis? How are you going to hire new people, and what roles are you going to put those people into? And how are you going to change the documentation, whether they're offer letters or employee handbooks or your summary plan descriptions, on a going forward basis to meet whatever strategic changes that you decide to implement? I think the more traditional item also that we'll consider and that we've talked about with some clients, changes to the type or cost of benefits being provided. As Larry mentioned, some clients that have historically looked at insuring their health benefits are now starting to look at self-funding, potentially changing the benefit structure, potentially changing the cost-sharing structure and shifting costs among single coverage or family coverage. I think historically a lot of employers have looked at it and said, we're going to do the same employer versus employee cost share on premiums regardless of the type of coverage provided. A lot of employers are now looking at changing that approach. And I think another reason why it's a timely opportunity to start your planning, we did have regulations that were issued, proposed regulations issued on the Employer Shared Responsibility Rule in January. We had a comment period that expired in March. Our firm had submitted comments on behalf of a number of our clients, and we're waiting to get the final regulations. Who knows when the final regulations will come out? I think we anticipate them early in the summer just because of the importance of these rules and the amount of publicity that's being provided to these rules. But until we actually have those final regulations, there are still some open issues. But we have enough information now that we can begin to plan and look forward to 2014. And in addition, what we're finding is that in some of the other areas, the guidance that's coming out from the federal agencies on healthcare reform, they're still continuing to issue guidance, but it's a little bit spotty in its applicability and its helpfulness. I think earlier today, Gail and I talked about one particular recent thing where the agencies pretty much said, Well, we think that the law is self-explanatory as written in the statute, so no further guidance coming from us on this particular item. And Gail and I said, this is one of the ones where everybody who's in the industry said, we have no idea what the statute means. We need guidance before we can implement it and before we advise people. I guess the real message here is don't wait for more guidance. Now is the time to start planning for compliance. And I guess just this last bullet on this first slide here, most companies, if they're looking at open enrollment on a calendar year basis, you're going to want to have those materials done by the fall. So waiting until after the summer to start putting together any changes is definitely going to be too late. So with that, we'll dig into the substance of the law, and Kristen will get us started.
I'm going to be talking about basic employer pay or play rules. So in the slide that you're looking at here, applicable large employers must offer full-time employees and their dependent children to age 26 affordable and adequate coverage or pay a penalty for every month in which that coverage is not offered. So this basic statement of the pay or play rule is what I'm going to be talking about for the next few minutes, and also Gil is going to be talking about part of that. Next. The pay or play rules apply to applicable large employers, and that is an employer who has 50 full-time employees on most business days in the previous calendar year. So this means for 2014, you're looking at the number of employees that you have in 2013 to decide if these rules apply to you. In counting the number of employees, you're counting full-time and seasonal employees, and then you're looking at part-time hours. And you're assuming that an employee works 120 hours a week, or excuse me, 120 hours a month, and so you're dividing the number of part-time hours to determine full-time equivalent employees. And it's the full-time, seasonal, and these full-time equivalent employees that determine whether you are an applicable large employer. You're looking at these numbers for each month. You're adding them together, and then you're dividing by 12 to figure out the numbers. So it's an average over the year. There are some special rules for employers that have seasonal employees that work for the employer 4 months or less, and it's those seasonal employees that bump them over the 50 employee rule. Those employees can be excluded. Also, there's a special transition rule for this year, so you can determine how many employees you have over a 6-month period instead of the 12 months I've just described. Now, counting the employees is sort of tedious, but it's relatively simple. The harder part of determining the applicable large employer is that it's defined on a controlled group basis. So for an example, if you have an employer with 10 employees, Company A with 10 employees, Company B with 45 employees, and they're in the same controlled group, you have 55 employers. If 55 employees in each company would be considered an applicable large employer under these rules. So the control group rules are very important. These are old tax rules. For those of us who work in employee benefits, we work with them all the time. We look at them for 401k plans, but they're more important now because for the first time, they're really attached to your health plan and the new penalties that may apply. So it's basically a new game. A control group, for those of you who haven't worked with them, it's determined on the basis of ownership or control or sometimes shared business relationships. A very simple example of a controlled group and ownership would be a subsidiary that's owned by a parent. If the parent owns 80% of the subsidiary, that would be a controlled group. There's something called brother-sister groups. For nonprofit organizations, controlled group is determined on the basis of control. So, for example, if one organization can appoint the directors of another organization, there's rules on control for nonprofit organizations that mean that they are in a controlled group. The thing about the controlled group rules, this is something your broker will not want to do, shouldn't do, and almost certainly will not want to do. They're complicated tax rules. But for an employer that's small or for someone that owns several businesses and each of those businesses look like they're small enough that they're not going to be caught by the pay or play rules, it's really important to look at control group status. Greg did a very complicated, I would say sophisticated analysis at the end of last year. We've done several in the last few months, trying to figure out is this company an applicable large employer or not. So that is the control group issue. Now it's the applicable large employer that we've just been talking about. The full-time employee that the applicable large employer must employ is someone who works on average 30 or more hours a week, and that's determined on a monthly basis. So the employer in 2014 will need to offer coverage to all full-time employees for each month. Now the IRS came out with proposed regulations and gave us a little bit of wiggle room. An employer only has to offer coverage to at least 95% of the employer's full-time employees. So there's a little bit of space there. Now this rule is very important because if an employer does not cover 95% of its full-time employees during a month, that will trigger what's called the sledgehammer penalty. It's the more severe of the two penalties under the pay-or-play rule, and Gail's going to be talking about those in just a moment. Now, sometimes you can just look at a plan and you know there's going to be a problem because you've required 35 hours a week, to provide coverage for an employee, or maybe there are groups of employees your plan is not covered. You can see by the plan design there's an issue. In some cases, it's not that obvious. For example, lots of employers have part-time employees. But for a particular month, you may have part-time employees working extra hours. And you could come to the end of that month and look and hear your part-time employees were actually working full-time hours and would need to be counted as full-time employees. So you could fail the 95% rule at the end of the month. In response to this sort of built-in problem of tracking, employers asked for more certainty in determining the status of employees. And the IRS issued rules with a look back and a stability period. And I'm just going to talk about those in very basic terms to give you an idea of how they work. The idea is that if you had a look-back period of 6 months and a stability period for 6 months, if you hired someone who was part-time for that look-back period, they would also be considered part-time for the following stability period. But this is a rule that has to be used, this look-back and stability period, not only for your part-time employees, but also for your full-time employees. So you could have a full-time employee who worked full-time and then switched to part-time status, and during the stability period, they would still be considered full-time. So I've tried to give you just a feel for these rules. In fact, they're very detailed. They're really tracking hours. They're tracking eligibility and tracking coverage. And for employers who want to use these rules, I mean, we'll figure out how to do it, but it's just different. It's different than the way we've kept data and information with respect to employee hours and eligibility and coverage. So we're going to need to learn how to do new things to use these rules. With that, I'm going to hand this over to Gail.
And this is the point at which I wish I really was a computer programmer so I could come up with a system that would track all of this stuff and get rich. And then I could quit practicing law. But unfortunately, that's not where my skill set is. So it does raise a good point, though. In the past, we've only really looked at when do people work. And one of the things that they change in those rules is you also count when people are paid for their absences, okay? So that's a game changer in terms of when you're crediting service for someone. A lot of payroll and HRIS systems don't track that information. So one of the things I think employers are going to have to be looking at is how am I going to keep track of this information? If you're in the process of looking at a new payroll system or HRIS system, certainly that would be something to take into consideration, is how it's going to count these hours for you, because these are records that you're going to have to keep. Moving on to the affordable and adequate. Remember, you have to offer coverage to your employees, their dependent children. Notice you don't have to cover spouses. They don't care about spouses. But at any rate, you have to offer them coverage that's affordable and adequate to completely escape penalties. So one of the questions is, of course, what is affordable coverage? The original statute came out and measured affordability based on household income. And employers said, I don't know what my employee's household income is. I don't want to know what my employee's household income is. I'm not going to ask for this. It's just not going to happen. So they came out with a safe harbor through a series of rulings last fall, and they came up with this idea that you would measure the employee contribution just for single coverage. Okay, so you're not looking at the family at all. You're simply looking at single coverage, and the employee's contribution has to be less than 9.5% of the employee's wages. And there are a couple of different ways you can measure that. One is you could use box 1 on the W-2. You probably don't want to use that one because box 1 excludes your 401k deferrals and your Section 125 salary reductions. Another one is you could take the person's hourly rate and multiply it by 130 hours and compare that to the monthly premium. And that's probably going to be the one that most employers choose. The third one you're actually measuring based on federal poverty level, which I don't think I would go there. So that's what we're looking at there. Now, one of the things that they did do is when this first came out, you had this discrepancy between what was affordable in terms of the penalty versus how would people get subsidies. Okay, because subsidies were measured based on household income. And they lined these up in a regulation that came out at the beginning of February saying, well, if it's affordable for the employee, it's affordable for the family, which I think is very interesting because if I'm somebody who was counting on getting that subsidy and now all of a sudden I have an employer that makes their contribution for single coverage within that 9.5%, but then I have to pay 100% of dependent coverage, that might not look so affordable to me, okay? So there's a possibility that somebody could challenge that regulation saying that the IRS went beyond the scope of their authority in cutting that back to the 9.5% of single. So that's kind of a little stay tuned idea. Adequate coverage. Coverage that's offered to an employee and employee's dependent children has to pay at least 60% of the actuarial cost of the plan. And very simply put, what they're thinking about there is if I have a whole series of things I cover, hospitalization, physician services, surgery, therapies, on and on, okay, what you would find in a typical health plan, if you look at that whole array of costs, on average the plan is paying at least 60% of those costs. Most employer plans are paying more than that. They're paying between 70 and 80%. So most employers, if they're going to get into trouble, are more likely to get into trouble on this affordability question than they would on the adequacy fee. So that brings us to what the penalties are for noncompliance. There are two penalties. One of them is the no coverage penalty. This is what we call the sledgehammer penalty. This is the one you don't ever want to inadvertently mess up, okay? This is the one, if you say, I'm out of the healthcare business, I'm an applicable large employer, I'm out of the healthcare business, I'm willing to pay this $2,000 a head, you're doing that based on a judgment and you know what you're into, okay? What you don't want to be doing, though, is to fail to do that, fail to offer coverage for a little over 5% of your people by mistake, find out after the fact when you can't fix it, and then you're paying $166.67 times all of your full-time employees minus the first 30, okay, plus all of the costs that you have in offering coverage to most of your full-time employees. So this becomes very important that you're keeping track of who fits into this category so that you don't inadvertently mess up this rule. Now the good news is this 95% rule gives us some wiggle room. If I have 1,000 employees, I have 50 people who could accidentally go over that margin, and I wouldn't have to worry about them for purposes of this penalty. They might cost me some money on the next one, but we'll get to second. So there are some planning opportunities, if you will. For example, I've worked with a client that had a particular category of individuals who were like student interns, and they had a lot of these, but there were only a very small handful of those people who worked more than 30 hours a week. So one of the questions was it better to offer coverage to the people in this category, or was it just better to pay the penalty? Cost, benefit, and philosophical decision for the business to make. The unaffordable inadequate coverage penalty, they call this the Tackhammer penalty, okay? Because even though the dollar amount is higher, remember the sledgehammer is $2,000 per person per year, this one's $3,000 per person, but it's only assessed for the affected full-time employee who goes out and buys coverage on the exchange and receives a subsidy, okay? So when, if I take my example of I have 50 people to play with, I have, say, 5 of them who weren't offered coverage, only one of them goes out and actually buys coverage on the exchange and gets a subsidy, then I'm only paying $250 for that person for that month, okay? So that's why it's a little hit as opposed to the big hit. One thing that's not on the slide I realized when I was looking at these is that this penalty is capped at what you would pay if you didn't offer coverage to anyone. So if you had lots of people in this category that you weren't offering coverage to, such that when you aggregated it, it became higher than your sledgehammer penalty, they would cap it at the sledgehammer level.
Yeah, and Gail, I think just adding on that, you had mentioned, I think, which was a good point, that on the sledgehammer penalty, that there may be some strategic opportunities for planning. I think for some clients, even on the Tackhammer penalty, there may be some strategic opportunities. And a couple of the clients that we've worked with that are maybe just barely over the 50 threshold, and they know their employee base really well, and they say, look, a lot of our employees, they're already receiving spousal coverage, or they're going to receive spousal coverage. They might look at what their current employee share of the premium is and say, we failed the affordability test on these 15 or 20 people, but we know that of those 20 people, that 15 out of the 20 are married and they're already on their spouse's coverage. The likelihood of them going out to the exchange, purchasing coverage on the exchange and triggering a penalty for us is really pretty minimal. And we're willing to kind of take on that exposure of having a handful of people that might trigger this penalty to try to keep our premiums at a little bit higher rate for those people who do end up taking the coverage. It's a little bit of a cost-benefit analysis and a risk-reward analysis of how comfortable that you are as an employer and taking. So moving on to the next slide, we've heard a lot about how much that healthcare reform is going to cost, and the estimate keeps skyrocketing and increasing over the years. And this slide demonstrates a couple of the things that are going to be a little bit more costly in 2014. And in addition, also mentioned some of the new plan design mandates that we'll have coming up in 2014. First off, in terms of plan design mandates, starting in 2014, there will be no annual dollar limits imposed on essential health benefits. The statute lists out a category of 10 different types of benefits that are considered essential. Up to this point, employers have been able to impose through their plans really pretty high dollar limits. Currently, that's a $2 million per year annual limit. Once we hit 2014, even the $2 million limit is gone. Actuarially speaking, I'm not sure how much of a difference that there is between a $2 million annual limit and a completely unlimited limit until you're that employer that has the $2 million worth of claims on one individual within that given year. The other item that becomes effective in 2014, no pre-existing conditions on any individual. Up to this point, healthcare reform had said you couldn't impose pre-existing condition exclusions on individuals under the age of 19. Starting in 2014, just flat out no pre-existing condition exclusions. And for the most part, I think a lot of employers have become used to the idea that most pre-ex conditions are going to be covered for many of their employees because of the HIPAA rules that have been in effect for a number of years and the concept of creditable coverage. Now even the people who might have fallen through those holes are in a position where you won't be able to impose pre-ex conditions on them. Another item that will be effective in 2014, a limitation on out-of-pocket maximums. This is something that would apply for non-grandfathered plans. It would apply for self-funded, large group insured, small group insured, as well as the individual market. And these are limits on the out-of-pocket maximums equal to the high deductible health plan out-of-pocket limits. Currently in 2013, those limits are $6,250 for an individual and $12,500 for family. And we just got, I think late last week, what the 2014 numbers will be, and those numbers are $6,350 for individual and then $12,700 for family. And then similar to the out-of-pocket maximum limits that a plan could impose, there's also going to be a maximum on the deductible that could be imposed on certain plans. This rule is only going to apply in the individual market and in the small insured group market, so large group plans, whether they are insured or self-funded, will not have to comply with this requirement. And the requirement is that plans cannot impose deductibles of more than $2,000 per individual, $4,000 per. Then when we get into the new taxes and fees, this first one, the acronym is the PCORI fee, the Patient-Centered Outcomes Research Institute fee, which is a lot of great words for basically saying we're going to try to study how to improve the quality of health care, and we're going to use this money that's collected from all insured and self-funded plans to help fund that research. It's a relatively small dollar amount. It's actually a penalty or a fee, I should say, that's payable already based on 2012 numbers. It's due, first fee is due July 31 of this year, and that's $1 times covered life under the plan. Covered life really is meant to take into account every person covered by the plan. So think about an employer that might employ 200 employees. Typically, if you're looking at how many people are actually covered, it's roughly 2.5 times your number of employees. So for the hypothetical, we're going to assume that the employer with 200 employees has 500 covered lives under their plan. The fee that they're paying in July of this year is $500. The next item is a little bit pricier. This is the temporary reinsurance fee. And I should note, too, that the PCORI fee will increase to $2 starting with 2013. It'll stay $2 per covered life for 2013 through 2018. The temporary reinsurance fee does not take effect until 2014. This is a fee that's a little bit larger. It's actually significantly larger. Now we're talking about $63 annually per belly button or per covered life. So again, if we're looking at this hypothetical employer, the 200 employees, the 500 covered lives, the $63 reinsurance fee works out to $31,500 annually. And this is a fee that applies to self-funded or insured plans. The idea behind the reinsurance fee is, we've touched on it a little bit, and we won't talk too much today about the exchanges, but the idea behind the reinsurance fee is that the fees that are collected through this particular tax or fee will be available for the insurers that do participate on the exchange to serve as a backstop for them in case they have worse than expected experience on the exchanges. So usually at this point, at least there's one employer that is sitting there thinking, so let me get this straight. I'm an employer that's providing health care. I'm continuing to provide it through my employer-sponsored health plan, and I still have to pay to help out the insurance companies that are going to be providing coverage on the exchange? And the answer is yes, at least for the next 3 years you'll have to do that. The last item here, the HIT tax, the health insurance tax, this is a tax that's imposed only on insured plans. And it is estimated to be, at least for this coming year, 2.5% of premium. We just heard today that that estimate might actually be a little bit low. There's a target dollar amount that the federal government is going to attempt to collect from all insurers. What we heard was that as some insurers move to nonprofit status, they will exempt themselves from this fee. While we've still got this target dollar amount that needs to be collected from all insurers, if some insurers move to tax-exempt or nonprofit status, that dollar amount still has to be collected from all of the taxable insurance companies. It's just going to mean that the premium that's imposed, the premium hit that's charged by those insurers, will be a higher dollar amount. So if we're looking at about, we'll still say 2.5% of premium until we get a better sense of what that number is. A typical standard employer, and I'll just keep going just to give you guys a sense of what the number might look like, continuing to use a 200-employee company. 200-employee company, typical family coverage or premiums per year might be around $12,000 a year. That's about $1,000 per month. And this $12,000 a year in premium, or $12,000 a month, a year per person in premium, is going to work out to about $2.4 million that the employer as a whole is paying. 2.5% of $2.4 million works out to about $60,000. So if you're an employer who is insured and you have around 200 employees, you can look at an increase in fees and taxes alone of around $92,000. That's without any other increase for any of your trend increase, strictly an increase in taxes and fees.
By the way, does it strike anybody as ironic that we have taxes on insurance, which is by far the largest portion of these extra fees? When you think about it, it's individuals and small groups that take up the bulk of the insurance market. Large employers, by and large, are self-funded, so they don't pay this HIT tax. Okay, so it's actually going to attack the very groups that this law was supposed to be advantageous for. Okay, it was going to make care more affordable.
Exactly. So with all of that good news about compliance and greater fees, a lot of employers at least initially ask, well, why not drop health coverage? And the first point is that the penalties that Gail's talked about are non-deductible penalties. So any for-profit employer is going to look at it and say, all right, I might have been paying about $10,000 a year per employee up to this point. Why don't I just pay a $2,000 per year penalty and be done with it, and I don't have to worry about any of the other aspects of providing health care? Well, first off, a $2,000 non-deductible penalty is not really worth $2,000. When you consider any contribution that the employer makes to the health coverage is tax deductible for a for-profit employer. Now you're looking at a non-deductible penalty, and when we talk to accountants or CFOs, they'll look at $2,000 of a non-deductible penalty and say that's the value of that is really somewhere between maybe $3,500 on the lower end and maybe say $4,500, maybe even $5,000 on the high end in terms of what actually has to be generated in revenue to account for payment of taxes and then payment of a non-deductible penalty to the federal government. So you're already eating into your savings. If you're thinking, well, I'm going to save $8,000 per year if I just drop coverage altogether by paying this $2,000 penalty, well, now it's really more worth about $5,000. So if you were paying $10,000 per person, now you've eaten away about $5,000. You might look at it and say, well, we still got $5,000 in savings that we'd have if we just dropped health care altogether. Well, health care is going to become, if it is not already becoming, a primary recruitment and retention tool. When we talk to a lot of employers, they just look at it and say, look, we're in the large employer market. We look at our competitors. Unless all of our competitors are dropping health care, we just can't afford to do it at this point. Maybe it's something that we'll look at in the future. Maybe we'll have to look at what our employee base is, how transferable or translatable that the skills are that our employee base has. to leave our industry and go somewhere else, but at least at this point, we're not looking to drop health care. We met with one employer, a pretty straightforward case, manufacturing employer. All their employees were generally making between $30,000 and $40,000 a year. They didn't really have any issues with affordability. They felt pretty good about their compliance, and they were starting to talk about, well, geez, maybe there's some things. Do we really want to continue to do this? This is a pretty expensive hit for us. And I said to the president of the company, look, you're telling me that the majority of your employees are making between $30,000 and $40,000 per year, and you're paying another $10,000 per year for insurance premiums for that. And you're wondering, well, what about our competitors, et cetera? What about a communication agenda to try to make sure that your employees really understand the value of the health care that you're providing to them? If you told all of your employees today, I'm going to give you a 25 to 33% increase in your wages, they would be doing backflips down the halls or through the shop floor. Part of it is going to be, I think, up to this point, and we've seen this universally with all the employers that we talk to, healthcare has just been a given when you hire a new employee. People rarely ask about it. They might get a handout that says this is what your premium is going to be, but it's assumed that you're going to get healthcare. Well, now there might be a little bit of value provided to you as the employer to make sure that your employees understand, yes, you're provided with employer-sponsored healthcare. You don't have to go out to the exchanges and look for it. And the value of this health care, which, by the way, is being reported on W-2s now, as you probably all know from having to do that on your W-2s this past year, the value of this health care is $10,000, and that's very valuable to you as an employee. Another item that comes up, and there's usually at least some controversy in the room here when we're talking to a large group of employers, employer representatives, this bullet point notes that likely the employer who dropped health care would end up increasing the taxable wages to help offset the loss of coverage. I know that a lot of employers look at it and say, well, why would I increase wages? And then they start to think about it, and as we said earlier, there still is a sense that a lot of employers care about their employees. They're paternalistic. They want to provide something for them. A number of employers look at it and say, well, I can't just turn my employees out to the exchange without giving them a little bit of a bump up in their wages to help them out when they have to go out and purchase the entire cost of the coverage, maybe with some subsidies if they qualify, on the exchanges. So, again, we're going back to our $10,000 cost. You took off $5,000 with the value of the non-deductible penalty, and now if you tack on another couple of $1,000s in taxable wages, which doesn't even get the employee likely all the way towards paying the cost, you've got another hit in terms of the value of the savings that might be available to the employer from dropping coverage. And then I think the final bullet point here, you read this every day in the newspapers. There's just so much uncertainty about the exchanges and how they're going to operate. We still have really no sense of how expensive the coverage will be for employees, how easy it will be for a lot of employees to use it. I mean, think about how difficult it is for you to run open enrollment right now for your employees. Think about how difficult it is to do 401k education for your employees. And now you're going to have millions of people turned over to exchanges with really no advocate or no assistance from their employers to help them through that process. I know that there is supposed to be the exchange assistant, I forgot the exact title, the navigators to assist people through. Color me skeptical as to the value of the navigators, and I apologize if there's anybody in the audience who would happen to work for this government and would dispute that statement. Again, moving on to other reasons why not to drop health coverage. I think we just talked in very broad sweeping generalities of kind of the big picture reasons not to. What about some of the more specific reasons that might be applicable to your particular business? Well, you've got options available. Again, I think we mentioned earlier the possibility of reorganizing the business. I think this is something that generally would be available only to smaller employers. It's actually something that, again, it would be extreme because you're looking at ways to break apart ownership to potentially avoid penalties through the breaking apart of a controlled group, getting back to those rules that Kristen discussed earlier. And here's an example that I can give you for one that I'm actually working on right now. We've got an employer that has two companies in their ownership group. They've got a company that does construction that has 80 employees. They've got a company that does long-term care, entirely separate and apart from the construction business, that has only 20 full-time employees. Together, they've got 100 full-time employees, and I should point out that the two companies are both owned by the same three individuals, equal ownership of each of the companies. So under the brother-sister control group rules that Kristen had mentioned, these two companies are considered part of the same controlled group. So we have to add together their employees, 80 plus 20, they have 100 full-time employees. Both of the companies are subject to the employer pay-or-play rules. And up to this point, when I was talking to the representative from the employer, he said, well, geez, we haven't offered anything to the people at the 20-employee company. It's something we just started a couple of years ago. We're trying to get them up and running. We want to provide them with benefits and health care on a going forward basis, but it's just an industry with a tough profit margin. It's difficult right now for us to try to offer health care. Do we have some options? And we're looking at it and saying, well, geez, if you just maybe, it depends on what the ownership group says, but if you just shift ownership from one of the individuals or a couple of the individuals in one of the entities to a fourth person, you can avoid the control group rules altogether. And I'll spare you the gory details of how you have to work through the rules, but it's essentially shifting ownership from control of more than 80% of the organization, which right now the three individuals control 100%, trying to shift it to only 75% control among those three individuals. And that gets them out of the control group rules. Yeah, jump in.
One thing I wanted to mention, if somebody is seriously thinking about breaking up a control group, it's going to make a difference for your other benefit plans. Your 401k plan, if you're no longer part of the same controlled group, you're going to have a multiple employer 401k plan. Your insurance contracts, life insurance, and the other contracts may need to be changed because they're not written for. So if you're doing this, it's going to be planning not only for your health but for your other benefit plans as well. And that's what I wanted to add.
No, absolutely. It's a good point, Chris. I mean, it's something that, again, should not be taken lightly. I think for this particular employer, they were looking at it and saying, we really, really want to avoid the health care reform rules for this smaller group, and we're willing to explore all options. Do we have options? The next item here on this slide, reorganizing the approach to hiring and staffing. We talked a little bit earlier about how do people get characterized as full-time employees. It's that 30 hours per week threshold. Well, depending on your organization, if you have a lot of people that you're worried about that are maybe in that 28 to 35 hours worked per week, and you've historically not offered them health care, you might be looking at ways to try to basically restrict their hours to ensure that they come in under the 30 hours threshold. And this is something that is really tends to be employer by employer as to how viable that this opportunity is or this option. Some employers look at it and they say, there's just no way that we can change our operations to try to limit hours so that we can restrict people. Other employers say, hey, this is great news. We've got all of the capabilities in terms of our software to be able to manage assignments and job assignments. This is a great option for us. I know there's one also employer that I'm working with right now that found themselves in this bind where they have people that have historically worked 28 to 35 hours per week, and they've never offered them health care. And I mentioned this possibility to them, and they just said, look, for us, these people are basically customer service for us. They're the face of our organization, and it matters to us to have the same people working on our same regular schedule. So it's just really not an option. So we had to explore other options for them. Other organizations, if you're in retail or restaurant industry or something along those lines where it's pretty easy to interchange individuals in the different roles, shifting around hours might be the way to go. We also got a bullet here on remixing the employee contribution levels. I think Gail kind of already addressed that, and noting that that affordability test is tied to the single contribution level and not the family contribution level. The other bullet here on revamping plan eligibility, I think this is just looking at ways to use those measurement and stability periods that Kristen talked about to your advantage to try to hold out people that you've historically held out as long as you possibly can to ensure that they actually meet the 30-hour per week threshold. And then the next slide here, just a couple of items worth mentioning on other options. Reducing the level or cost of coverage through traditional plan design mechanisms. These are just ways to essentially control costs. If you're looking at dropping healthcare coverage, well, why not just look at ways to control your costs, and it might mean cutting benefits as an option. If you have some flexibility to meet that 60% actuarial value threshold and still have your coverage be considered adequate, adjusting the benefits might be a better way to go rather than dropping coverage altogether. And then the last item on this slide, reducing cost of coverage by just flat out improving that quality of health and the quality of care using wellness, disease management. All of these things would, in theory, drive down your claims experience. Driving down your claims experience drives down your cost. It makes health care more affordable. So with that, I will toss back to Gail for a brief discussion on the Cadillac tax.
Obviously, this is not happening in 2014. It's supposed to happen in 2018. We've heard rumors that this might actually be repealed. Someone asked me the other day if it was going to be accelerated. I said, God, I hope not. But these numbers, the 10,200 single and 27,500 family, are set for 2018. They are not going to go up between now and 2018. And I've worked with employers who have benefit plans that already exceed these levels. Okay, they have very rich benefit plans. And so they're already looking at this 40% excise tax, and it's only taxed on the amount that actually goes over those amounts. But if you look at an 8 to 10% trend on healthcare costs, if it keeps going up like that, it doesn't take a lot before you're talking real money there. Some employers have been using this as an opportunity in their collective bargaining to try to persuade unions that they should not have such rich benefits so that they don't have to pay the 40% because the employer tells them that they won't. Currently, we don't know anything that tells us that the employer can't pass the excise tax on to the employee. So stay tuned for more guidance on that. And there are a lot of things we don't know about this yet because HHS has way too much on its plate to worry about this. But if you are an employer that has very rich benefits, I think it is something to tuck in the back of your mind as, yes, you can, right now you need to worry about 2014, but you can't totally ignore this. It's something that you may have to plan for going forward. So who should evaluate this? Everybody, okay? There are some employers that have, especially high risk. If you have a lot of variable hour employees, if you have seasonal employees, lots of part-timers, and the problem with part-timers is they get hired to work 25 hours a week and no one pays any attention to how much they work after that. Oh, you're classified as part-time, you don't get benefits. This changes that whole concept. If you have low-income employees, people who are only making somewhere between $8 and $16 an hour, they might be a 9.5% problem for you. And of course, if you have full-time definitions in your plans now that are over 30 hours a week, you're going to have to scale those back and consider the people who will now automatically become eligible for coverage. There are also some industries that we've identified that are especially high risk. Healthcare and long-term care. On the employee benefits side, by the way, I speak about long-term care as anything that includes nursing homes, hospice, assisted living, et cetera, et cetera. I realize that if you're a healthcare person, those all have different meanings, but that's what I mean by long-term care. They have a lot of employees who tend to be in this low-income level, and they're in industries where they have to provide care 24/7, okay? So if I'm operating assisted living or hospice or something like that, and I have an aide who doesn't show up, and I have to have somebody else working overtime to make that up, that's just the way it is. It's not like I can say, well, we're just going to leave this bed unattended. That can't happen. Another, entertainment, the restaurant industries, other hospitality industries have a lot of part-timers, variable hour employees, low-income employees, and so forth, and the retail industries. seem to be very, very hard hit by these rules.
I think with that, we'll mention at least a couple of examples or case studies, kind of building on what Gail was just talking about, where we got a mention of certain industries that we know are particularly challenged by the law. One thing I think that we wanted to mention is whether you're a smaller employer or a larger employer that will be subject to these rules. If you're between 100 or if you're well over 1,000, this is something to be considered in any sort of M&A context. I know Larry has talked about this, and he has this flagged as a concern for him and any deals that he's working on. If you're acquiring a company, what are you really acquiring? How many new employees are you going to have to account for under the healthcare reform rules? And how many more are you going to have to account for than you may have had to if you had made this same acquisition 2-3 years ago? A really stark and extreme example of this is a situation that we were started to get involved with, fortunately, after the acquisition, I guess maybe unfortunately for the individual who made the purchase. It was a controlled group of multiple companies, and the manager of one of the companies wanted to purchase that company that he had historically managed. The company had between 40 and 50 full-time employees, depending on the given month, and a number of part-time employees, and the hours worked by those part-time employees pretty much ensured that this one particular company standing on its own would be considered an applicable large employer. That goes back to the rules on counting part-time employee hours that Chris mentioned earlier. So the individual made the purchase accounting for the number of people that had historically been on the controlled group's health plan, which was around 5 people. So he was thinking his exposure, if he was even going to offer any health care, would be about 5 people. He also thought, well, I won't even really have to offer it because I'm not technically going to be an applicable large employer. I'm going to be around 40 employees. The way it ended up working out is that he is an applicable large employer. He now has potentially penalty exposure if he doesn't offer to the 50 full-time employees. Or he's got a big ticket in terms of an annual cost in providing health care that he hadn't anticipated having when he purchased the business. And for an individual who had purchased the business in a relatively small transaction, this is a big cost item that was not anticipated. So whether you're, again, the 1,000-employee employer or if you're working with organizations that are a little bit smaller, take into account health care in terms of M&A. Kristen, I think you've got some thoughts there too.
Well, I just wanted to mention that when we put the M&A impact, we were talking to our corporate partners and other partners within the law firm. So I guess this is a comment to the lawyers in the audience, but it means if there is a sale or a transaction, there needs to be a lot more review of the health plan issues and the potential liability that's there, particularly for this next year or two when we're in this transition. We all really need to look at it. We want to make sure it's not our client that has a horrible problem. So that's all I wanted to add.
The next, I guess, set of examples, the control group challenge. You've already touched on this a little bit, so I'll just try to briefly go through. Kristen had mentioned I worked with a fairly sophisticated and complex arrangement at the end of last year. Essentially what we had was a holding company that employed around 80 full-time employees. And the holding company had significant investment in 250 different smaller companies around the country. Each of those 250 smaller companies, the nature of the business was such that they were only employing about 2 to 4 full-time employees in each of those 250 companies. Historically, the holding company provided health care to their 80 employees, but they'd left whether health care was provided to any of the 250 smaller entities up to those individual entities, whether or not they wanted to offer coverage. Well, when they started looking at this for purposes of health care reform, it turns out that they actually were a controlled group under the complex controlled group rules, under some of the very specific and detailed exceptions and exclusions rules. And all of a sudden, the president and the primary owner of the holding company was looking at this and saying, So you're telling me that the 250 companies, which have about 1,000 employees, now have to all provide health insurance, and if they don't, we've got a penalty that's going to apply across the board for the entire organization. So a penalty of 1,000 full-time employees times $2,000 a year, he was looking at about potentially a $2 million annual penalty if just one of those organizations didn't provide the health insurance. Thankfully, we did get the proposed regulations that we've talked a little bit about that clarified exactly how these rules apply. The penalty applies on an individual entity-by-entity basis, which, I think he said he went from turning over every night in his sleep to, just turning over once a week in his sleep thinking about this. And then we shifted the focus in helping this organization to how do we now communicate with all of these entities that think that they only have 2 to 4 employees, that they're now subject to this law that applies to applicable large employers, when in their mind there's no way, shape, or form that they would ever be considered an applicable large employer. So it took a little bit of careful and creative drafting in terms of communicating to those entities and helping them out with their communication pieces. I think the next item, Gail, you're going to talk a little bit about the high-risk employer again.
Yeah, I've worked with a number of long-term care organizations on this, and just as an example, I had one that had about 800 people who worked 40 hours a week or more, because they classified full-time as 40 hours a week, is what most of us used to before we had this backdoor mandate. They had another 50 people who were working between 30 and 39 hours, so they were not eligible for their self-funded health plan at that point in time. So that's 50 individuals potentially you're looking at offering coverage to, and then the associated costs that go with that. Their wage range for most of their employees was $8 to $16 an hour, probably average somewhere around $11. Their single employee contribution was rather high compared to market. Average in this area is supposed to be something like 20 to 25. We always are looking at each other going, boy, I don't know who those people are, because we have a lot more employers that are charging like a third. And that's about what these people were, charging for single coverage. But for these people who were making such low wages, for their lowest end, it was more than 20% of their wages for single coverage. And for the top end, it was still over 10%. So they had a lot of issues to look at. If they hadn't done anything to fix this 50 people that we were talking about, that right there would have been $1.6 million a year in penalties if they hadn't, done something with that. And then we were looking at, okay, depending on what we did with the affordability of it, how many people would migrate, to the exchange and get subsidies. If you were talking only 50 people, that's like $150,000 a year. So these are very challenging things, and particularly in that industry, I really feel badly for people who are in that industry, because some of them are nonprofit organizations that get a lot of their money from Medicaid and Medicare, and we all know that those costs are being driven down. So it's not like they're McDonald's and they can go out and charge more for a hamburger to make up what they're going to have to find or pay penalties for in terms of these coverages.
In terms of the vanilla employer example, I think this is just trying to emphasize the point that really no matter who you are, you should be concerned about exploring compliance with this law. This particular company, they had a couple of different locations. When we went in and met with them, they said, hey, look, we're in great shape here. We've always provided coverage to people who work more than 30 hours per week. We generally charge a pretty low rate in terms of employee share of the self-only coverage. It's only around $100 a month. So we should be fine on affordability. We've got a decent benefit plan. We're all set. And we started talking to the representatives of the employer and asked them questions like, well, what about, do you vary any of the premiums or any of the eligibility requirements among your different locations? And all of a sudden there was, oh yeah, that's right, the one location, they use a 40-hour per week threshold and not a 30-hour per week threshold. Well, that's an easy thing that we're going to have to attack. Well, what about part-time employees? Do you employ any part-time employees that are around the 30-hour per week? Oh yeah, we do hire some people, and we categorize them in this kind of generic casual employee category, and they work as we need them. And we've got at least 5 or 10 people in that category, and they could work anywhere between 30 hours per week and some weeks, 20 hours per week in other weeks, or 40 to 50 hours per week in other weeks. They're really people that work as we need them. Well, we probably need to do something to deal with those people and whether or not we need to offer coverage to those people. So what we found in each of our meetings with employers is that when it might look initially like you don't have any concerns under health care reform, once you dig into who you're actually covering and all the different categories of employees that you might have in your organization, you'll find that you might have at least one thing or two things that you're going to have to change at some particular point.
One thing that I wanted to mention is for employers, and I don't want to get into the legal rules for this because all of this is enough already, but employers using leased employees, you're going to have to look at that and see whose employees they really are in the arrangement that you have for leased employees. So.
Okay, on the Cadillac tax challenge, I think that was, we actually used to have a handout for that, but it really goes more to the looking at where your costs are now. Are you already over, or are you going to go over if you put 8 to 10% per year on the cost of your coverage between now and 2018, and then thinking about what are you going to do about that if the tax stays in effect. Are you going to look at cutting back your benefits? Are you, going to pass the cost on to employees if you're allowed to do that? Those sorts of things. But it's kind of a backseat issue to the 2014 compliance.
And that really brings us to the end of the presentation here. We just got this last slide that reiterates some of the things that we've been talking about throughout the afternoon in terms of action items. And with that, we can turn it over to the audience for any questions.
Is there any
Yeah,
Repeat the question.
Yep, sorry, I was actually just going to remember to do it. The question is that the broker has brought to the employer the proposal to change the plan year, the actual plan year, from January 1 to later in the year, November 1 or December 1, to try to postpone the effective date of these rules. Is there any downside to that? I know Gail's probably jumping out of her seat because she and I have had a number of discussions about this, and we've heard of a number of insurers that are proposing this, as well as brokers and consultants that are talking about it. So, Gail, do you want to?
Well, the definition of a plan year, there's a hierarchy, okay, and the first definition of a plan year is what do your published materials say? If you're complying with ERISA, if you're in an ERISA plan, you're supposed to publish an SPD that tells what your plan year is. A lot of smaller employers who have been insured haven't done this, okay, so they never published a plan year, okay. So then what do you look at? The next rule is you look at whatever year your deductibles accumulate on or your limitations within the plan. Most plans have either deductibles or limits or both. Most of the time, those are calendar years, even if you had a policy year that's other than that. So if you didn't have a published plan year in your document, then likely your plan year is going to be whatever your deductible year is, which is usually going to be a calendar year. So when you have insurance carriers that are coming out and saying, well, we'll change your policy year, and that'll change your plan year, that's not true. Okay, to actually change the plan year, you would have to, if you didn't have one published, you would have to go out and publish it. If it is already published, you'd have to, to issue an SMM, a summary of material modification, saying this is our new plan year. The problem is for the shared responsibility rules, they tell you right on the face of the rules that you can't change this to avoid or delay compliance. We will ignore it if you do that. So you can't go there. Now, smaller employers, those are that are in the 2 to 50 lives where they're below the shared responsibility rules, okay? It may look a little different for them in terms of doing this. We've generally not been encouraging employers to do this, but if you're in the small employer group and the insurer says we'll change the policy year and you also want to change the plan year and you feel comfortable doing that, that you're not going to get into trouble with anything else like the shared responsibility rules, you could go ahead and do that. The caveat that we would offer is that I don't know if the agencies are aware of this possibility that the insurers are doing this, because they could always come out and say, for any purpose, you can't change the plan year to delay anything, and that would kind of put a screeching halt on it. So if you decide to go forward, proceed with caution. Okay. The rules say that if you have an hourly employee, you have to actually count their hours. If you have non-hourly employees, you can use equivalencies, either an 8-hour-a-day equivalency or a 40-hour-a-week equivalency. That's 8 hours per any day in which the person would perform at least 1 hour of work or be paid for 1 hour for absence from work, or the same rules for a week, 1 hour of work in the week, or 1 hour of pay for being absent that week. You could impute 40 hours, all right? That's great, except that it has to actually reasonably reflect how much the person works. And what they're worried about is there are some companies that have like 36 or 12-hour shifts. So if you took the 8-hour rule, you could underreport someone and say they weren't eligible. Okay, so that was their big concern. There is a flip side concern that they haven't addressed yet, and that is if you impute, say, 40 hours a week for your people who are not hourly employees, they tend to be your more highly paid, right? And we have waiting in the background some time down the road these non-discrimination rules that are going to apply to insured plans that are not grandfathered. They haven't published those rules yet, okay, because they were supposed to go into effect the first plan year on or after September 23, 2010 for non-grandfathered plans. And the IRS figured out that there were all kinds of problems with the rules that were out there, and they said, pending further guidance, we're not going to enforce these. We've heard rumors that they are going to publish these rules perhaps later this summer. Usually they give us until the first plan year on or after 6 months after publication of the rule. So if they publish the rule like in August, that means if you had a calendar year plan, you might have to comply in January of 2015. Anyway, the point I'm getting at is, let's say you have people who are maybe working 20 hours a week, and you know typically that's what they work, even though they're non-hourly, they're commissioned, or however you keep track of them. And so then if you impute the 40 hours for them, are you overstating, and then they're getting a better deal than the hourly employees? So that's one of the concerns. So, right, exactly, and that's why they came up with the equivalencies. And my concern was on the flip side, okay, because I do have some employers who have people who don't work typically 30 or more hours a week. They know that they don't, and I'm worried about the flip side saying, well, that's discriminatory. I don't know how they're going to resolve it, and the IRS wouldn't give me an answer when I called them.
I think that this is, to me, if I'm an employer, this is a disaster.
Yes, it is.
I think if I'm an employer, I don't want to have anything. Hire a bunch of human resources and benefits management people. It's going to drive up costs, and we can't even imagine all the ways that this will drive up costs. So
why wouldn't an employer say, you know what, tomorrow all of my employees are going to be terminated? So that they can deduct all the payments they make for health insurance.
Okay. The response was what would stop employers from turning all of their employees into independent contractors?
Yes.
Okay. Unfortunately, there are tests that the IRS uses for common law employees. So even though you try to turn them into independent contractors, they won't be.
You have a question?
Okay.
I have a question. Let's say I'm an employer. I have 1,000 employees, and I've got 2,500 lives. I decide that I'm going to get a clinic, an in-house clinic with a doctor, a nurse practitioner, a medical assistant. Doctor. They're not going to cover if that person has a heart attack or breaks a leg, but I've got a doctor in-house. How does this affect my client? Affect if any does it have? I think you probably looked at that the most. One of you two.
We're going to give this one to
Oh, good. I think you raise a very good question, and I don't know how the agencies are going to respond to that, because one of the questions, and actually I think we just got some additional regs on the minimum value rules. The question was, if I have an on-site clinic, right, for my employees that basically provides all of their primary care. It's not going to cover their hospitalization. It may not cover certain specialty services, but that's going to be their basic clinic for primary care. How does that affect these rules? And I don't know how the agencies have addressed that in the minimum value rules. They just came out like a couple of days ago.
Right, and I don't think it is addressed in the minimum value rules. I don't remember seeing anything about the on-site clinics.
Yeah. So to answer your question, there should be some way of valuing that as part of your minimum value. Okay. Usually with an on-site clinic, your people are not paying a lot for those services, or they might pay a $25 copay per visit or something. It just depends. Okay, so they're not paying a lot for those services. Certainly that shouldn't create an affordability issue for you. All right. So the question would be, how would it fit into the minimum value? And I honestly don't know the answer to that off the top of my head, and I'm not sure they've taken it into account.
It's clearly a group health plan.
Yes, it is clearly a group health plan. Okay. And the minimum value calculator, I believe, is optional. You
Correct.
can have an actuary value your plan. So if you have an on-site clinic and then it coordinates with a major medical plan that provides the services that are off-site, there has to be a way for an actuary to value that for you. Okay?
Yeah, I know that
Mm-hmm.
the major medical,
Correct.
because it's going to decrease the basis on it.
Correct.
And so we're that way.
Mm-hmm.
I'm just wondering if it had any.
I just don't think that the agencies have fully comprehended how to work in the on-site clinics into everything that they're doing. They're struggling with wellness programs, which I think in terms of how many employers have them, you probably have more employers that have wellness programs than that have on-site clinics at this point, and they're struggling with incorporating the value of wellness programs into the minimum value rules and the affordability rules. Those were addressed, at least briefly, in the regulations that came out just on Friday.
Mm-hmm.
But I think that they're at a loss as to what to do with on-site clinics.
Sure.
Right.
Mm-hmm. I would guess that it combines a lot of things. It probably combines wellness. It combines first aid for people who need a Band-Aid or an aspirin or whatever, which has traditionally been like the the nurse on the floor kind of idea in a manufacturing environment. It may also do some occupational health, which would really be workers' comp. Okay, so you've got a lot of roles going on for this clinic, and I think Greg's right. The agencies really don't have a clue.
Let me jump in a minute.
Yes.
There is some real entrepreneurship going on in that area, and I'm having conversations with businesses who are looking at that, and there are entrepreneurs who are in that business of embedding clinics in employers or in industrial parks or in office buildings, purpose of really driving down not only emergency room visits and walk-in business, but really to take on the whole issue of the kind of long-term health issues that really drive up costs, like high blood pressure, diabetes, smoking, and all that. So it's happening. To put a plug for one of our clients, we have a client that is in that business called NIS Clinics. They're doing it primarily in school districts, but they also offer a product for the for-profit business. To me, for groups that are large enough to self-insure, again, subject to the rules that you guys may encounter, it just seems like there's something compelling about that if you're able to take the costs way down and manage them yourself through that kind of a mechanism.
There is a lot of value to doing that. There are some legal hoops you have to go through, both from a health law perspective as well as from an employee benefits perspective to do it properly. Okay.
Have they ruled on how health reimbursement accounts and
you want to take this one?
Yeah, the question is, have they ruled on how health reimbursement accounts or health savings accounts would coordinate with these rules? And this was addressed a little bit just last week, that the amount that's provided by, in terms of, if we're trying to measure the minimum value test, that 60% threshold, the value of what's provided by the employer does count for, if it's an integrated HRA or if it's an HSA, employer contribution counts towards what the employer pays on meeting that 60% actuarial threshold test. I think that they also said that they were going to try to get more guidance out on exactly how we do the test for an integrated HRA versus a non-integrated HRA. There has been some guidance on that in the past, but I don't think it's always been the clearest guidance.
And that's pretty much outside of these rules. Yeah. Although if you start getting fancy with the look back and stability periods, which basically if you adopt those rules, you have to adopt them for all your full-time employees, I would think you would probably want to have pretty much everybody in that same plan, because otherwise you have to run two different sets of rules.
Yeah. Oh, sorry, one more thing, Gail. It's just to build on that idea. You know, the idea is if you're offering the coverage for people who are under the 30 hours per week, are they pretty much outside of these rules? Yes, they're outside of a lot of what we talked about today, the employer shared responsibility. Your plan still has to comply with some of the other Affordable Care Act rules, things that have either been in effect prior to today that we haven't talked about, or a couple of those items like on the essential health benefits, the no annual limits. There's also a 90-day waiting period rule that a plan can't impose more than a 90-day waiting period after the individual becomes eligible for coverage. So there's a little bit that you can do strategically in terms of structuring the eligibility requirement for your part-time people. And again, by part-time we now mean under 30 hours per week. But in terms of worrying about the shared responsibility rules, yeah, those people are outside of these rules.
I wanted to respond to one of the questions that came over the webinar, and the question is whether an employee's subsidy to the employee is there some way to do this not under a 125 cafeteria plan approach? And I think what this question is asking, or at least what I'm going to answer is that if the employer is going to have the employee pay part of the cost pre-tax, taken out of the employee's paycheck, the only way you can do this is through a cafeteria plan. So it's just important to remember that. Yes.
Employees possibly falling in and out of that. How does that then? There's rules under.
All good questions to which they haven't supplied answers.
Yeah, I mean, the question was, are there problems with people dropping in and out of coverage, and what do you do with your cafeteria plan or your 125 plan, which restricts how people, yeah, there definitely are issues, and I don't think we've worked our way through, and there's no guidance on that level yet.
Well, one of the questions, for example, is if you go to these look back and stability periods, what happens to COBRA? Because they haven't repealed COBRA, right? Wouldn't that be nice? That might make some of the pain worth it. But unfortunately, they're not doing it, at least not yet. But then the question becomes, let's say I have a look-back period that goes from October 15th to October 15th, and then my stability period runs the calendar year, okay? So I have somebody who in the look-back period met the 30 hours, and then in February of calendar year, they actually reduced below that. They changed to an on-call status. Now, for the rest of the stability period, I have to offer them coverage, right? Because they met the 30 hours. When's their COBRA event? Under the current COBRA rules, the qualifying event is when they actually reduced the hours. So theoretically, unless they change something, I could say, well, my 18 months starts running when you went to this on-call status, and at the end of the year, I only have to give you another 6 or 7 months of COBRA. Somehow I have the idea that the agencies are going to come out with guidance on that. Call me a pessimist, but I would suspect that they're going to say you have to start running the 18 months at the end of that stability period. But those are questions that they have not answered.
Well, let's go this
gentleman? Okay. All right.
Have the rules gotten very specific? This must be included in it.
You can do that one.
I think we've got a couple of things coming into play. One in terms of, oh, sorry, thanks, Gail. The question is, what if, do we have specific rules in terms of what coverage must be provided under the law? And if so, what mechanisms are in place for providing a waiver to the employer so that the employer doesn't have to provide that specific coverage? There's a couple of different answers. The first answer is that in terms of specificity of what has to be covered, if you are in the individual or small group market, what has to be offered and provided is generally considered the essential health benefit package. It's a listing of 10 different statutorily designated categories of coverage. It's things that you would typically expect in a lot of plans. Your medical insurance for hospitalization, your rehabilitative care, et cetera.
Be in your insurance contract.
Right, and this would be in the insurance contract. Now, if you're a large insured, if you're in the large employer insurance market, or if you're self-funded, you do not have to provide any of the essential health benefits in terms of what coverage you have to provide. If you're going to actually provide minimum essential coverage, which is a different term under the law, who knows really at this point what you have to provide minimum essential coverage, but you don't have to provide each and every one of those essential health benefit categories. So that's kind of the first answer. The second answer, really the things that I can think of that are coming out as new mandates on coverage are for non-grandfathered plans. Certain preventive services and certain women's health services have to be provided at 100% coverage. And when we're talking about preventive services, we're talking about a lot of your tests to try to prevent your catastrophic illnesses and to try to identify things. The U.S. Preventive Services Task Force provides a listing of the items, and the regulations on preventive services cross-reference that listing. The women's health care services do include contraception, which is a hot-button issue for a lot of nonprofit organizations that have religious objections, as well as for for-profit entities that are owned by small business owners who have their own personal objections to providing that type of coverage. I know that there are at least, I think, 2 or 3 lawsuits pending in federal court on the for-profit side, as well as one massive lawsuit pending on the nonprofit religious organization side, objecting to that type of coverage. But there are some methods that are available for religious organizations that have objections to providing the coverage, but frankly they're not all that well fleshed out right now. It ends up being essentially a runaround so that the organization doesn't have to provide the coverage, but in terms of who has to actually pay for it, it's not really clear as to the ability of a third-party entity to charge that back to the organization. So at this point, still pending resolution of certain lawsuits. The question is, for the small group employer that is subject to the essential health benefit package, does that include dental and vision? And the answer is no, generally speaking, but strangely, one of the categories of essential health benefits is pediatric oral and vision care. And I think you can look at this and try and split it however many different ways as to what exactly constitutes. First of all, we finally know pediatric means under age 19. We did get guidance on that. But in terms of what benefits actually have to be provided, do you have to provide glasses for children? Do you have to provide contact lenses for children? I know that most of the major vision carriers have actually taken the position that the hardware is not part of the essential health benefits package. That's an assistance in terms of trying to provide, making it easier for people to see. For me, I wear glasses and contacts. I think it's pretty essential to have those two things, but I can understand why that might not be characterized that way. So what it looks like is that the essential health benefits package would actually be covering the visit to make the determination or the annual review for the child as to whether or not they need some assistance. Correct, yeah. I mean, we actually spun out for a couple of our, when we were looking at this, just generally speaking, what is the essential health benefits? Can you impose dollar limits on them? Because that's been in effect for the last few years for small employers, large employers, self-funded plans. But for a number of our larger self-funded plans, they were asking about orthodontia, and because they'd historically had, say, a $1,000 per year or something like that limit on orthodontia. A lot of plans were pretty aggressive in taking the approach and saying orthodontia is actually cosmetic. There's no requirement that you have your teeth be straight, so we're going to treat this as something that's cosmetic, and accordingly, because it's cosmetic, it's not part of the essential health benefit package. And we can provide it, but we'll provide it with a dollar limit on it, and we're going to continue those dollars. And no formal guidance from the agencies has come down to say yes or no to that approach.
Fortunately, our 3 panelists will be here to answer any questions during our cocktail hour, and we have hors d'oeuvres outside as well. So please join us. Thank you.
Dan Schweitzer said today